So it's 9 p.m. exactly, Cairo local time, and it's our weekly time for our Wednesday didactics. And we are one lecture away from finishing the endometrial cancer module. We only have the last but not the least lecture next week. Dr. Amr knows the last Wednesday is going about screening, not about endometrial cancer. So welcome everyone. I hope that my voice is clear and my screen is clear too. If you have any questions, please feel free to interrupt me anytime by putting your questions in the chat or Q&A box, and we will answer it either in between the cases or in between the slides or at the end. And today the topic is very interesting, one of the most favorite to my heart, which is about oncofertility, and this time is about the balance between cancer control and preserving fertility in endometrial cancer. And again, I usually mention everywhere that being a surgical oncologist, we have been always accused of being so aggressive, caring about the oncological part, not caring about the functional part or the fertility part in gynecology. And that's why we feel super sensitive for that topic, and we try to preserve fertility as much as we can in ovarian, endometrial, and cervical cancer. And I claim now that in OCMO we have one of the largest series of fertility preservation in all types of gynecological cancers. So we are very aware about this part. Why the screening share is out? That post. النهارده يجي كده احنا ايه؟ I already shared my screen right now. Now my screen is clear. So if we started our cases by a real case scenario from Egypt, she's a 29 years old female. She had delayed pregnancy, abnormal uterine bleeding, and she was obese, having some sort of polycystic ovarian disease. She was in Alexandria, and her gynecologist performed a hysteroscope for her, where he encountered multiple endometrial polyps. He removed those polyps, Dr. Ahmed Kamal from Alexandria, and sent the polyps for histopathology, and the picture was scoping with moderately differentiated endometrioid carcinoma, FIGO grade 2. And at this point, Ahmed contacted me in Mansoura and asked, now she's grade 2 endometrioid adenocarcinoma. She's 29 years old. She has got no offsprings. Is there any chance for fertility preservation? And that was a very nice point from Ahmed, because she went to another 3 or 4 gynecologists in Alexandria who told her, you have to remove, you have to take your uterus out, and you have to remove your uterus because this is endometrioid carcinoma. So with a discussion with me and Ahmed, and as I left the names to know how we are working as combined even between Mansoura and Alexandria, I told him the first step is to do pathology revision to be sure is it grade 1 or well differentiated, because I have encountered many cases that were diagnosed as endometrial intraepithelial neoplasia and turned out to be grade 1, or grade 2 and turned out to be grade 1. And so we sent to one of the well-known labs in Cairo, and I have personal communication with Dr. Shadi Elia. And the revision stated that it was endometrioid adenocarcinoma grade 1 on top of endometrial hyperplasia with atypia, which we call EIN, or endometrial intraepithelial neoplasia. So it is not grade 2, it's a grade 1 endometrioid adenocarcinoma. And again, as we are not speaking theoretically, and as you have the molecular classification, I had the honor to speak about molecular classification of endometrial cancer, and we said what's available in Egypt and what's not available. So we asked Shadi to complete the molecular profiling. We asked it for ER receptor status, and for the mismatch repair and P53 mutation. And it was mismatch repair proficient, not mismatch repair deficient. So there was no mismatch MSI, no microsatellite instability. And she was ER positive, PR positive, and it was wild type P53. So there was a P53 mutant. It was the aggressive part. It is not mismatch repair deficient. She was PR receptor positive. And then again, I asked him to have an MRI to be sure. He told me that he removed all the polyps, So I asked him that we are going to have an MRI and a new hysteroscope. And again, when you are doing an MRI, you should choose a good place. This is a very crucial decision based on the MRI. So I asked him to send for Dr. Heba Hassan, and I speak about the names. She is a very well-known radiologist in Alexandria. She has many presentations with us in the Egyptian Gynecology Society. And I asked him to refer the patient to do a post-contrast MRI, pelvic MRI. And again, I felt that I was right in my decision because I had one of the best ever MRI reports I had seen in Egypt, referred back without any communication with Dr. Heba. But she stated that the radiological opinion, there is still no definitive myometrial invasion. This is very important to see if there is myometrial invasion or not. On MRI basis, provisionally FIGO stage 1, T1A and 0MX, and the radiological suggested intrauterine endometriosis as described above, no extrauterine disease, no suspicious cervical lesions on current imaging base, no suspicious vaginal lesions, no suspicious adnexial lesions. And I ask you to read how she was precise and speak about every point that we need for this case. And that was her image. So let's go to our presentation. Why would we think about fertility in endometrial cancer? Because simply, I believe that the vast majority of gynecologists, when they see a case of endometrial cancer, they will think immediately about doing hysterectomy. And I claim that all of the surgical oncologists who are going to see a case of endometrial cancer, they are going to do hysterectomy, and even if hysterectomy is not indicated, because we are aggressive enough. So why we have to think about fertility? What I have told you before, in my sheet, in my clinic, I added an item about fertility issues and fertility wishes of the patient. For any patient, breast cancer patient, thyroid cancer patient, ovarian cancer patient. So my assistant must ask the patient if she is premenopausal about her fertility perspectives. Is she wishing for fertility? Does she have children? Does she need more children or not? So this is very important. So this should be routine in your history taking in gynecological cancers. So why think about fertility? Because fertility simply is a quality of life indicator. Most of the women usually dream about being a mother. Increasing average age of first pregnancy was used to be in the first early 20s to early 30s, because usually women all over the world are not being married early now as have been used in the last decades. So all over the Western and Eastern world, the age of marriage have been delayed. And 14% of endometrial carcinoma are diagnosed in premenopausal women. 4% of those are diagnosed under the age of 40 years, like our patient that we have just stated before Ahmed Wael was here. So when to think about fertility? Sure, women of reproductive age who wish to preserve their fertility. Again, it's appropriate counseling. What are your perspectives? Do you wish to have still children? Again, I can have a patient who is 25 years old and she has got no children and she wants to move her uterus and to have the standard of care. And it is very logic that this should be reserved for low-risk endometrial carcinoma and a typical endometrial hyperplasia, the balance between oncological safety and fertility preservation. This should be reserved only for the low-risk endometrial cancer. We can't do fertility preservation for a serious endometrial cancer or for endometrial carcinosarcoma, blah, blah, blah. Again, what do we require? We have to know what's understanding the risk of deviation of SOC. Do you know, Ahmed, what's SOC? The word SOC, when we say it in oncology, it's a standard of care. So the standard of care, there is a standard of care, and the standard of care in endometrial carcinoma is hysterectomy, plus or minus lymphadenectomy, blah, blah, blah. So when we shall deviate from the standard of care based on guidelines and evidence-based, it is not the standard of care. The standard of care in endometrial carcinoma is hysterectomy. So am I allowed to do deviation from this standard of care? Yes, I can do. Simply in stage 1A, grade 1 endometrioid type 1 endometrioid, adequate stage that by MRI and biopsy, and a very important point that she should be compliant with active surveillance and hormonal treatment. So if this patient is not going to come again and again, if she is illiterate from faraway village, she can't understand the surveillance part, okay? And if she can't have the hormonal treatment, so you can't go away from the standard of care and you should offer her hysterectomy after good counseling. This is simply the whole presentation that we are going to say again along the whole presentation. So I'd like to invite all of you after this presentation, when you have time, to read this very important paper. ESGO, ESHRI, ESGI. ESGO is, of course, our beloved European Society of Gynecology, and ESHRI is the European Fertility Association, and ESGI is the European Society of Gynecological Endoscopy, okay? They do a consensus or a combined guidelines for fertility-sparing treatment of patients with endometrial carcinoma that was last year in 2023, published in 2022, okay? And this year, they published another guidelines for the whole gynecological cancers. So I invite all of you to read these papers. It will be enough. You can just quit our presentation or omit having our presentation and just go and read this paper. It's a very easy written, really, by Alexandros Rodakis. He's a very good friend from Greece. So the general recommendation about patient selection: patient with a pregnancy wish, she should have a wish for pregnancy. If she doesn't wish, why would we do deviation of standard of care? She should be referred to specialized care, especially those with genetic syndrome. Level of evidence 5, grade A evidence. So those with like Lynch syndrome, for example, should be referred for genetic counseling. And then we have to do a joint care counseling with a multidisciplinary team, gynecological oncologist, fertility specialist, pathologist, and radiologist. They should be all there proposed to patient with a pregnancy wish. Again, I'd never be bored of saying the problems that we have passed and all the arguments that we have passed before. This is nothing to unreveal, okay? Because this is something for everyone to learn. When we have a very, very long, stubborn discussions with our colleagues in gynecological departments, okay? Why is post? No. It's post. Sorry for that. I stop share and I reshare again. Where's the presentation? Technical problem. Give it the presentation back. And I should go share again. Share the screen and the presentation. Okay. I'd work from not full screen, excuse me, because of this repeated problem. Okay. So again, when we had this long discussions with our colleagues in gynecological department, one of the statements that we always hear that you shouldn't, you know nothing about fertility preservation, you should refer for us all cases that need fertility. And again, my point of defense was no. What's fertility preservation? Ovarian cancer is to remove just one ovary and the tube. In endometrial cancer, we know what to do. In cervical cancer, we can do the trachelectomy. So we, as oncosurgeons who work as gynecologists, and you, as our colleagues, respected colleagues in the gynecological unit, we must both refer to the fertility unit in gynecological department. There is a unit which is fertility unit, and we should discuss in MDT and take the decision. This is the way to protect the fertility of our patients, not just to refer the patients from the surgical oncology unit to the gynecological oncology unit. So gynecology unit is a unit, and fertility unit is another totally separate unit. Whenever you have a patient who is premenopausal, you have to discuss with our colleagues in the fertility unit, not in the gynecology unit, about the fertility perspective of this patient and how can we protect her fertility. That was my point of view that I always state. Okay. So about the reproductive potential, okay, again, the consultation with the fertility specialist, not the gynecologist, we should go and ask, do the AMH, do the LH, do the FSH, know what about her fertility consultation. Age-specific age limits, women should be counseled about the reduced chances of achieving Aleph pairs with their own gametes with increased age, as she is older than 35, for example. She will have less chances for live pairs rather than blue 35. And in studies including women up to age to 40 years, live birth rate was 23% was reported. So we have to discuss with the patient. And again, I'll tell you, I had a patient who was 41 years old who wanted to preserve her uterus. She had endometrial carcinoma grade 1 on top of endometrial intraepithelial neoplasia. I was in Morocco. I presented this case in Casablanca in the Par School, and I told them that I told her, even if we manage to manage your tumor, your chances of getting pregnant is very low. And I told her, she was in Cairo, I told her, your chances, she was, I believe, 42 or 43, your chances of getting pregnancy and having a live birth, a good child, is like the chances for Egypt to win the World Cup. Okay? And I was speaking about something impossible. And when I was presenting this presentation in Casablanca, I said, but the Moroccan team managed to go to the semi-final of the World Cup and to be the fourth on the world. So nothing is impossible. She can have her chance. And really all our Moroccan colleagues had very, very good clapping for me about after saying this word, okay? So you discuss with the patient, you tell her honestly her chances of getting pregnant, of getting live pairs, and then she will choose after knowing clearly her choices. Again, these are from the ESGO ESHRI guidelines, review of initial pathology by experienced histopathologist. And as you remember, again, the case that we presented in the start, before Ahmed Wael was here, we requested for a second opinion by an experienced histopathologist, Shadi, in fertility sparing history. This is a must. If you work as gynecology, you should always bear in mind that you should have a very efficient gynecologist, and you usually have a very low threshold to revise again and again and having a second opinion if you had a pathology from some pathologist that is not specialized or that you don't know, so you can repeat again, especially for the crucial decisions. Because the distinction between atypical endometrial hyperplasia and well-differentiated adenocarcinoma show poor inter-observer and inter-observer agreement. Do you know what's intra-observer and inter-observer agreement, Ahmed? Intra-observers, it's the same, okay, the same observer can, if you see the same slide, can say it is EIN, and then he can say it is grade 1 endometrial carcinoma. And inter-observers that if you have two observers, then see the same slides, one of them can say it is grade 1 and the other one can say it is good. So even the same observer, if they have the same slide twice, he can say this is grade 1 and this is endometrial intermediate hyperplasia. Okay? So always remember, it's very crucial to have a good, competent gynepathologist and to have a personal communication with the gynepathologist, and never hesitate to have a second opinion and to have a second look after this patient. Okay? The grade 1, grade 2, grade 3 tiering system, we know that we have the binary grading system. We divide the endometrial carcinoma into grade 1, into low grade and high grade, but we all prefer the grade 1, grade 2, grade 3, and this is the one preferred by the ESGO and ESHRI guidelines. It is recommended to use the grade 1, grade 2, grade 3, not the low grade and high grade tiering system, okay? Again, the differentiation of the tumor. The fertility sparing treatment is considered for endometrioid patients only, not in serous, not in clear, not in carcinosarcomas. With endometrial carcinoma with grade 1, not grade 2, and not high grade, and not undifferentiated tumor. A very important, stage 1A, you can never put a full stop after stage 1A. This is stage 1A without myometrial invasion, because we used in the last FIGO classification 2018 that all of you know, that stage 1A is having less than 50% of the myometrial invasion, okay? So again, you can have a patient with myometrial invasion and say she is a stage 1A, she is candidate for fertility preservation. No, the tumor shouldn't touch the myometrium, shouldn't invade the myometrium. It can touch but not invade the myometrium, okay? And without risk factors, okay? With risk factors means lymphovascular space invasion, positive with the presence of lymph nodes, for example, and of course, no extrauterine disease. The evidence for grade 2 endometrioid adenocarcinoma is limited. So fertility sparing treatment should be discussed on case by case. So our case was grade 2 in the start, and then when we do the pathology revision, she turned out to be grade 1 on top of EIN. Establishing reliable histopathology, again, hysteroscopic guided biopsy is much preferred than blind biopsy for confirming diagnosis. So again, when we are doing fertility sparing treatment, I've never, ever depend only on DNC and the blind biopsies or paper biopsy or something like that. I must have hysteroscopic biopsy. And back to our case with Dr. Ahmed Kamal, we said that we do MRI and then bring her back to the OR, do a hysteroscope to be sure that we have removed all the polyps. Myometrial invasion, again, should be performed by MRI or transvaginal ultrasound by a specialized radiologist, the same that we say about Dr. Hiba Hassan. And the standard high-quality protocols for MRI should be used to reach the highest possible accuracy. Please, again, whatever, if you think one day to be a good, competent gynae oncologist, you should know your tools. You should know your weapons. So you can take a very crucial decision of doing fertility preservation of endometrial cancer for a 30 years old patient against the opinion of many gynecologists and oncosurgeons who ask for hysterectomy based on a very poor quality MRI or on poor quality histopathology, and then she had a recurrence or metastasis or relapse within very few months, and then you will be always blamed because you must use all your tools. The best pathologist, the best radiologist, and you should know them, and you should help in their training, and you should encourage them to be in your team. Because again, gynae oncology is a teamwork. It's never a one-man show or one specialty show. CT is not used for assessment of myometrial invasion. We don't need CT, and again, we have discussed this once, twice, and thrice in the endometrial cancer module, that MRI is the gold standard for pelvic imaging in endometrial carcinoma. And of course, and goes without saying, it's a default that we had to exclude extrauterine disease. You can do fertility preservation with a patient with abdominal peritoneal disease or lymph nodes or lung mets or something like that. This is insane, okay? So I believe that no one ever of you will consider fertility preservation for a patient with a stage 3 to 4 endometrial cancer. So when to think about fertility, okay, again, pregnancy wish. Pregnancy wish is high in endometrial cancer. And with pregnancy rate, we had like 66% of patients who had pregnancy wish had pregnancy rates, and 72% of them reached live births, and the recurrence was in 34.7% of those patients. That was a very nice paper that was presented by Sarah Nath last year. I saw her complete response in 80% of the population. So now we know which patient we are going to offer the fertility preservation. Those who wish pregnancy, of course, those in the premenopausal age, better to be before 40 or before 35 years old. And again, grade 1, stage 1A, no myometrial invasion with good molecular profiling that we are going to say right now, okay, and with no risk factors. Those are the patients whom we are going to offer fertility preservation. What's fertility preservation? What we are going to offer those patients? It's hormonal therapy. So we use either systemic progesterone or local progesterone. We use the local Mirena loop, okay, which is progesterone long releasing progesterone IUD. So you insert the Mirena loop, and this is present, and this is found in Egypt. You can find it easily. It was deficient some months ago, but now it is present in Egypt and is used for bleeding and for hyperplasia, and it is used, so it is easy for any gynecologist to insert a Mirena loop for any gynecologist. And systemic, what we call medroxyprogesterone acetate or megestrol acetate, which is the trade name is Megas. We use the Megas, okay? It's 160 milligram, high doses of progesterone. You give very high dose of progesterone. And it's preferred to use the combined approach to insert locally the Mirena loop to release the progesterone locally and to add the Megas orally, okay, for that. For those who are willing to go to real life in Egypt, you will not find the Megas in Egypt. It hasn't been here for 2 or 3 years now. So we ask the patients to ask her relatives to bring it from Saudi Arabia, from Turkey, from Gulf region, and usually they manage to bring it, okay? And whenever I ask my patients to bring quantities of them, and I have some Megas to use for my patients until they found it, this Megas. So you are trying to solve the problems in the real life. The remission rates, 75% will have a CR. What's CR, Sahar? It's a complete response, okay? So complete response across the literature that 3 out of 4 patients will have a complete response, okay? So this is treatment algorithm. It's very easily. The diagnosis of endometrial cancer, okay? And then I do the counseling with her, the pregnancy wish, her chances of getting pregnant, of getting a full healthy live birth, the assessment by the age, the risk factors, the BMI, diabetes mellitus, hypertension, fertility wish. I do the staging using MRI with a good, efficient radiologist, a good hysteroscope and biopsy, and be sure that I have no residual disease inside. And then counsel the patient about oncological safety, our pregnancy plan, surveillance plan, and then I do hysteroscopy and biopsy in 6 months interval again, either every 3 months or every 6 months. Once I do the hysteroscopy and biopsy twice or one time in 6 months, I'll find either CR, either complete response, or persistent or progressive disease. Either it was persistent disease or progressive disease or complete response. If I have a complete response, of course, I'd encourage her to do pregnancy at once using reproductive specialists, not waiting for normal pregnancy, and use the IVF and the ART assisted reproduction. Okay, and once she gets her baby, I will offer her hysterectomy with the cesarean section. Okay, or with the delivery, I will offer her hysterectomy. So she got her baby and she received her wish. Can she go for another pregnancy? This is something that can be discussed case by case. We don't recommend, but it's written in the literature, and there is many studies about it, and there are case reports or case series about patients who got pregnant once and twice. But our hope is to have one baby. Okay. So, for example, I had a patient. I have usually spoken about her for the last years. She was 37 years old. We had a complete response for 2 years, but she didn't manage to have a partner. Okay. She was very beautiful, but she didn't have any partner. And then at the age of 40, she had a relapse on our routine hysteroscope. I told her that I don't have any data to go for follow-up more than 2 years, but she wished to go for follow-up. And in the 3rd year, I performed a hysteroscope for her. I found a recurrent disease, and we offered her hysterectomy at once. We removed the uterus. It was grade 1 endometrial carcinoma with synchronous ovarian endometrioid carcinoma, a very small lesion in the ovary, stage 1 by the new FEV classification. And it was a case that I always remember because she went to Ain Shams University. They told her, you are stage 3 because you have ovarian and endometrial. But again, according to the new FEV 2023, she is stage 1A, not stage 1, not stage 3. Okay. If I have a persistent or progression disease, I continue the hormonal treatment, the local and the systemic, and I'll do interval 4 to 6 months recounseling and reassessment by hysteroscope. The questions that I usually encounter by our dear gynecologist colleagues, every time I have to remove the loop with the hysteroscope. No, you can go with the hysteroscope with the IUD inside, and I'll show you the video right now, and remove it back. And for the patient, I had done for her 3 or 4 hysteroscopes with the IUD inside, but in the 5th time, the IUD was displaced, and I had to insert another Mirena loop IUD. Okay. So this is the paper that I encourage all of you to join us by Rodalikis. Rodalikis is a very good Greek friend, and he is inviting all of you to join us in Athens in the last of November in the Mimago. They are holding the Mimago in Athens this year, and Alexandros is the one who is inviting all of us. He's the coordinator. Again, if you remember the case that we presented before Ahmed Wael was here, we asked for estrogen and progesterone status. Okay, all the world now know, Ahmed, that you were late. All the world, from South America to Asia to Europe. So estrogen and progesterone expression seems to be predictive of response in conservative treatment. If she is ER positive, PR positive, she has high rates of complete response. That's why our patient, if you remember, she was ER, PR positive. Okay? Negative or ER negative, PR negative is not contraindication for fertility sparing treatment. However, they had inferior results rather than our patient, but our patient was ER positive, PR positive, so we were more and more encouraged to do for her. What about the molecular profiling? We will do the promised molecular classification. We know to know the pole mutated states. It is not present in Egypt by NGS. We do the mismatch repair deficiency, the P53. Okay, so she was P53 wild type. Okay, not mutant, so she is not the aggressive part. She was mismatch repair proficient. Okay, and again, immunohistochemistry for identification of mismatch repair deficient is mandatory to identify patient at high risk for Lynch syndrome if she has MSI or mismatch repair deficient. So she is high risk of Lynch syndrome. If Lynch syndrome is identified, patient should have appropriate counseling of having additional cancers like colorectal cancers and blah blah blah. Okay, so it wouldn't be so nice to do fertility preserving if she is mismatch repair deficient. But our patient was mismatch repair proficient, not deficient. And in women harboring copy number high P53 tumors, conservative therapy wouldn't be appropriate because we all know now that P53 abnormal tumors are or mutant tumors are very aggressive or have the worst prognosis, and our patient was P53 wild, not mutant. Okay, so this is the Marina loop. This is our photos from our hospital, and this is a video. Okay, that after inserting the Marina loop, and then we do a hysteroscopy with the Marina loop inside, it will appear just in. Sorry for that. So you can see the endometrial cavity now, and this is the IUD in place. Okay, you have Saralog through the whole uterine cavity, through the cornea, and you find it in place with both horns, and you can find no gross lesions. That was my patient that I was speaking about just right now. And even with those, you have multiple random biopsies. Okay, we have multiple random biopsies from inside to be sure that we have no residual disease, and if she is present, you can either go for another 6 months or you can remove the IUD and start ART. So the selection of medication is combined approach consisting of hysteroscopic tumor resection followed by oral progesterone or the Mirena loop. It is the most effective fertility treatment to use both of them. Okay, some people would use the gonadotropin releasing hormone analogs. I didn't experience it there before, and hysteroscopic resection is much more important than the DNC, blind DNC, and the dose of migastrol acetate is 160 to 320 doses. Okay, the duration of treatment is 6 to 19 months to 12 months, half a year to 1 year. If we have a complete response, we can remove now it, and the maximum time to achieve complete response is not to exceed 15 months. So if by 15 months you don't have response, you have to stop and do hysterectomy. For our patient, she had a complete response, but we had a follow-up longer than that. But if she didn't achieve complete response, if you every time find for 15 months, 3 times, 6 months, 6 months, 6 months, you find residual disease or progressive disease, you have to remove the loop and to stop treatment and to refer her for hysterectomy. In the absence of any kind of response at 6 months, no response, you should do an MDT counseling to see case-by-case bias. The response, you will ask her for weight control again, and you see the partial response versus complete response versus no response. And the follow-up maintenance therapy, as I told you, every 3 months is to do and to consider it. 3 to 6 months, it's free. You can remove the IUD, you can stop the treatment and refer for a pregnancy specialist or for fertility specialist. Okay? The woman undergoing fertility sparing treatment or endometrial carcinoma should be encouraged to actively aim to conceive as soon as complete response is achieved. Again, our case that was delayed, she developed a recurrence after 3 years. And the assisted reproductive technique, the ART, should be considered in order to improve success rates and to reduce the interval of conception without high risk of recurrence. However, natural conception may be considered in women with good reproductive potential. So she is young, like our patient, and she's 29 years old. You can tell her, I leave you for 3 months, for example, to try to conceive by natural conceive pathway. If not, we will refer for the assisted reproductive technique. Okay? And the close surveillance should be continued after that. So, the visions for the future, molecular profiling as predictor for successful conservative management. We will add more and more because the future is all molecular now. Office hysteroscopic procedures for easier surveillance. So we don't have to take care for the OR every time. We just do the office hysteroscope and assess the management. The tight window for fertility sparing treatment in the endometrial carcinoma is highly curable. So you can give her further periods of follow-up. And there is a problem that faces in the Western countries that many patients undergoing fertility sparing treatment choose not to achieve pregnancy, or either they don't have a partner like our patient, and so we have to have more insight into family planning. So she wishes pregnancy, and once she achieved, she say, no, I don't want to get pregnant, and so we have more insights into family planning behaviors and into the partner wishes. And finally, I'd invite all of you to attend with us the 8th ago to mark your calendar in the 12th of December this year in Cairo, to meet all the experts from all over the world. And I invite you to go through the EGO's website and search for the fertility sparing and role of hysteroscopy. This presentation was presented last year or 2 years ago by Ursula Katina from Gemelli, and really she had a much better presentation than me, with much better videos and much better quality of hysteroscope. So my presentation is not enough. You should go and continue the hysteroscopic part, because she's a very expert in hysteroscopy and fertility preserving. So you just go to the Egyptian Gynecological Society website, go to the endometrial cancer part, and endometrial cancer, search for the fertility sparing Ursula Katina, and you will find the presentation on our Facebook page and then YouTube channel. Really, it's a very wonderful, interesting one that I couldn't compete. And that was my presentation, and I have 2 questions to answer. One from Dr. Tariq Al-Hawari. He is asking about 41 years old female, primary infertility, and she has polypoidal atypical endometrial hyperplasia with focal endometrial intracellular neoplasia with generalized stroma. What's your opinion? Again, this patient mostly will be searching for pregnancy. It's not my part to say for her you are not going to conceive. My role as gynecologist, that I say, yes, she has polypoidal atypical endometrial hyperplasia, you have a chances of cure. I can offer you fertility sparing management, but this is in MDT with the fertility specialist. If the fertility specialist says that she has got some chances, up to, he can say up to 10%, 20%, 30%. Again, we can discuss with her and she will choose. But I myself, I don't assess the fertility potentials of the patient or the fertility perspectives. I assess that he is candidate for conservative or not, and then after counseling with the fertility counselor, we can reach him. If he said it's impossible for her to get pregnant after that, I should inform her about that. But again, remember that some population would never like to remove her uterus, even if she is 70 years old, even if she is 65 years old. And if she has a chance, for example, we offer fertility sparing management, not fertility sparing, but conservative management for all females with grade 1 endometrial carcinoma, very old, morbid obese, and she can, for example, have surgery. She is morbid obese, diabetic, hypertensive, some sort of renal problem. So you would offer her only conservative. It is not now fertility preserving, it's conservative management. So you can offer her that, okay? If the patient doesn't wish to remove her uterus, it is not your uterus, it is her uterus. And she is candidate, you can leave the uterus for her, okay? So do we have any other questions? Yes. It's 160 milligrams, okay? So you can give once daily, okay? But again, you can give 1 to twice, 160 to 320 milligrams per day. However, remember always that those patients are young, and the megas has the side effects of getting obese and the thromboembolism problems. So usually I had encountered this with 2 patients that they stopped megas because they got too obese, and they want to stop megas, so stop it after 6 months and only in the IUD, okay? On the Melina loop, because they want to lose weight, they don't want to be so obese. She was beautiful and nice.
I was not because I always did that. So 160 to 220, but I don't know why the weight based on the weight of the patient.
Yes, it is the weight of the patient, because
no, I don't think that she's getting more weight. The patient was higher weight can take higher dose.
I don't know. Really, because there is no consensus on that. You can even only, if you see, you can go only on the IUD, in the local IUD. You can add megas, and you mean the dose of megas is different, okay? So I believe it's case by case discussion, yeah.
I have another question, but I think you answered it already. The dose, the time that I can continue on the experiment.
It's written up to 2 years. You can go. I went for 3 years for one case by myself, but we had a recurrence and ovarian synchronous lesion in the 3rd year. But it is written that you can go for 15 months if you still have persistent disease. If the problem that we should discuss, if you already had the complete response, but she doesn't have a partner.
Yeah, that's
yes. Really, this is something, because in the Western world, she can have get pregnant without a partner. Okay, this is not allowed in our locality or our culture. Yes, counseling was here the same I did with my patient. I counseled, I stopped the megathrelia because and I continued on the doctor treatment, but I had like closer period of follow-up, not every 6 months, but every 3 months. Okay, and once she developed the recurrence, it was very early, and we picked the hair.
before.
Yes, yes, but this is not written in the literature. So, any other questions from our virtual or physical attendees? Thank you. So, thank you for all our virtual attendees. I believe no one have questions. I'm happy that you are here, Ghazal, Dizal. I hope you got some information. And next week, we are going to finish our endometrial cancer module with the best finishing is Dr. Amra Bozena. He's going to speak about the ESGO guidelines in the endometrial cancer. He will summarize everything that we have said throughout the module. And next week or the week after, we are going to have an exam about the endometrial cancer module. Okay? Okay. Good night. Good evening for all of you. Thank you.